Welcome back to The Explainer. Today, we are stepping into the shoes of a medical detective to dissect a seriously fascinating clinical puzzle. We've got a single, highly specific physical symptom, and our goal? Well, we're going to try to reverse engineer it to figure out exactly what's going wrong on the inside. Let's look at the evidence.
Okay, let's dive into this. Take a look at the patient here. Sitting on a hospital bed, they definitely aren't just resting normally, right? They've adopted this striking, honestly deeply uncomfortable looking posture, kneeling, face down, with their knees pulled tightly into their chest. This isn't just someone taking a nap. This is a highly specific, instinctual physical response to something catastrophic happening inside their body. In the medical field, this curled up stance is actually a formally documented sign.
Now, just for some quick context, this isn't just a random snapshot we found online. This comes directly from a surgery and gastroenterology medical education series. So this is a highly curated, high-level challenge, specifically designed for medical professionals to test their diagnostic skills. We are operating squarely in the intense world of acute gastrointestinal emergencies.
So here's the core challenge presented to us. The praying position sign is seen in which condition? I want you to keep this exact question in the back of your mind as we go. Every single visual clue we unpack today is about connecting this outward sign to its hidden internal cause. To help us solve this, we're given a lineup of 4 usual medical suspects. We've got A, appendicitis, B, cholecystitis, C, pancreatitis, and D, perforated ulcer. 4 very distinct, very severe GI crises. Our job is to figure out which one of these specific emergencies forces a human body into this exact kneeling stance. Now, what's really interesting about this slide is the actual psychology and physics behind the posture, like why this exact knees to chest position. When we experience intense visceral pain, our bodies instinctively seek out pressure relief. Lying flat, well, that stretches the abdomen out. Standing up lets gravity pull down on all those internal organs. But curling into a tight little ball compresses the front of the abdomen and stretches out the retroperitoneal space in the back. So, which suspect causes pain that's specifically relieved by folding completely forward?
Look closely at the language here, because it holds a massive clue. Notice we have 2 entirely distinct categories of medical trauma. On one side, we have 3 inflammatory conditions. The itis conditions, appendicitis, cholecystitis, pancreatitis. These are organs that are swollen and, frankly, very angry. On the other side, we have a structural failure, a perforated ulcer, which is literally a hole in the GI tract. So we really have to contrast the physical response triggered by deep inflammation versus a sudden structural rupture. Let's think about our first 2 inflammatory suspects, the appendix and the gallbladder. Now, we know both of these cause absolutely agonizing pain, for sure. But does their standard presentation typically force a patient onto their knees, bowing into the mattress? We really have to weigh the anatomical location of these specific organs against the profound physical relief this patient is seeking. So the crucial point is that it truly becomes a giant spatial puzzle. We have to deduce which of these 3 organs, the appendix, the gallbladder, or the pancreas, sits in the body in such a unique way that its inflammation causes pain so deeply radiating that bending completely in half is literally the only mechanical escape. And then we have to look at our outlier, option D, the perforated ulcer. Think about this. If a patient is leaking gastrointestinal contents straight into their abdominal cavity, would they instinctively assume this praying stance? Actually, scratch that. Wouldn't they be completely rigid, terrified to even breathe or move? Because any tiny shift causes agonizing friction against an irritated abdominal lining. We have to contrast the mechanics of peritonitis against the mechanics of retroperitoneal pressure relief. Oh, and you might notice that little DRA signature at the bottom. It's just a subtle, kind of fun reminder that this isn't some algorithmic multiple-choice test. It's a carefully crafted educational tool designed by a professional to test your observation and logical flow. The answer is completely hidden in the anatomical details placed there intentionally for us to decode.
And this brilliantly illustrates the whole picture, bringing all the evidence together. We have the acute clinical hospital setting, we have the ongoing medical care indicated by the wristband, and above all, that unmistakable defensive posture. The knees pulled tight, the upper body collapsed completely forward. It is a textbook physical manifestation of a very specific internal battle, captured perfectly in a single frame. Okay, we've walked through all the context, we've analyzed the physical mechanics of pressure relief, and we've contrasted inflammation against structural failure. Now it is time to lock in your hypothesis.
You have to weigh the visual evidence strictly against the 4 options we've got: appendicitis, cholecystitis, pancreatitis, or perforated ulcer.
So, what does this all mean? We've laid out the evidence, the anatomy, and the mechanics. But in the world of diagnostic medicine, the final call is yours. Look at the choices one last time. Based strictly on the visual clues we've uncovered today, which is your final diagnosis? Lock in your answer, keep questioning the evidence, and I'll see you in the next explainer.